This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the journal PloS, published in 2026. The title is, Can AI applied on MRI reliably predict shunt response in INPH? A comprehensive exploration of deep learning and radiomics approaches using preoperative MRI.
This is a topic that hits home for anyone in a neurosurgical clinic. Idiopathic normal pressure hydrocephalus, or INPH, is one of those few treatable dementias. We see these patients all the time, the classic triad of gait disturbance, cognitive decline, and urinary incontinence. But as every resident and attending knows, the million-dollar question is, who actually gets better after we put in a shunt?
Exactly. We have the clinical signs and we have the structural MRI showing the enlarged ventricles, but the predictive power of those traditional radiological measures, like the Evans Index, is often quite limited or conflicting in the literature. This study, led by Clara Mogensen and her team at Umeå University, really pushes the envelope by asking if artificial intelligence can see what the human eye might be missing on those preoperative scans.
It's a bold attempt. They looked at a cohort of 149 shunted INPH patients. For an INPH study, that's actually a very large and robust sample.
It is. And they didn't just use one type of imaging. They investigated preoperative T1-weighted, T2-weighted, and FLAIR images. Their primary outcome was improvement in gait speed postoperatively, which is really the gold standard for clinical response in these patients. Out of those 149 patients, 113 were classified as responders and 36 were non-responders.
That distribution is pretty typical for what we see in practice, roughly a 75% response rate. Now, Alara, they took 3 distinct AI approaches here. Let's break those down for our listeners, because AI is often used as a catch-all term, but the methodology here was quite specific.
Right. First, they used a deep learning approach with 3D convolutional neural networks, or CNNs. They actually tested 2 different fusion strategies. One was a late fusion ensemble, where they trained separate models on each MRI sequence and then combined their outputs. The other was an intermediate fusion model, where the features from T1, T2, and FLAIR were merged within the network itself.
And the second approach was radiomics, which is a different beast entirely. Instead of letting a neural network learn features from scratch, radiomics involves extracting thousands of predefined quantitative features, things like texture, shape, and intensity histograms from whole brain masks.
Then they used those radiomics features to train more traditional machine learning classifiers like linear discriminant analysis, or LDA.
So we have the cutting-edge deep learning versus the feature-engineered radiomics. I remember reading the paper and thinking, finally, we're going to get a definitive predictive tool. But the results were, well, they were a bit of a reality check, weren't they?
They were. Despite using these advanced techniques, the performance across all models was considered poor. None of the models reached an area under the receiving operating characteristic curve, the AUROC, above 70%.
That's a tough pill to swallow for the AI enthusiasts. What was the best performing model in the main group?
The top performer for the whole cohort was actually a radiomics-based model. It was the linear discriminant analysis classifier using only T1-weighted images, and it achieved an AUROC of 63.7%. To put that in perspective for our residents, an AUROC of 50% is basically a coin flip. So 63.7% is better than chance, but it's certainly not something you'd want to base a surgical decision on in the OR.
And they tried to clean up the data to see if that helped, right? They created a reduced subset?
Yes. They looked at a subset of 72 patients who were clearly separated, meaning they were either definitive responders or definitive non-responders, removing the gray area patients. In that specific group, the best model was the late fusion ensemble of 5 CNNs. That one reached an AUROC of 69.2%.
Still under that 70% threshold. It's interesting that even when you only look at the most obvious clinical successes and failures, the structural MRI alone, processed through the most advanced AI we have, still can't reliably tell them apart.
It raises a big question. Why? The authors point out that INPH is incredibly complex. These patients are usually over 80 years old, prevalence is about 7% in that age group, and they often have significant comorbidities. We're talking about Alzheimer's pathology, Parkinson's, and small vessel ischemic disease.
Exactly. An MRI might show standard INPH ventriculomegaly, but the structural scan might not be capturing the underlying physiological reserve or the degree of irreversible white matter damage that prevents a patient from responding to a shunt. The paper suggests that structural MRI alone is simply insufficient for this task.
I liked how the authors were very transparent about the limitations. They mentioned that traditional radiological measures show limited predictive accuracy, and their study confirms that even high-dimensional AI analysis of the same images doesn't magically solve the problem. They recommend that future research must move towards multimodal input.
And that makes perfect clinical sense. In practice, we don't just look at the MRI. We look at the TAP test results, the infusion testing, which the paper notes are often the first line of invasive tests, and the patient's clinical history. The authors suggest that for AI to be useful here, it needs to integrate these clinical data points with the imaging.
They also emphasize the need for large multi-center datasets. Even though 149 patients is large for a single-center INPH study, it's actually quite small for training deep learning models, which often require thousands of examples to generalize well.
For the residents listening, I think the takeaway here is twofold. First, don't over-rely on the AI label in new software. Look at the AUROC and the validation metrics. If it's under 70%, it's a research tool, not a clinical guide. Second, it reinforces the value of our clinical workup. If the most advanced 3D convolutional neural networks can't predict gait improvement from a T1 scan, your clinical judgment and the CSF TAP test are still your best friends.
It also highlights the black box nature of some of these models. The study used things like whole brain masks for radiomics. Perhaps by focusing on specific regions like the periventricular white matter or the colossal angle specifically with AI, we might see different results in the future. But as of this 2026 study, the comprehensive exploration says we aren't there yet.
It's a humbling reminder of the complexity of the aging brain. INPH is a treatable condition, yes, but its mimics are many, and its radiological signature is shared by many who don't benefit from surgery.
The authors conclude by saying that to capture the complexity of the condition and enable clinically meaningful predictions, we need that multimodal approach. It's a call to action for better data sharing across neurosurgical centers.
Well, Alara, I think that's a perfect place to wrap up. A big thank you to Mogensen and the team for such a rigorous study. It might not have given us the perfect predictor we wanted, but it certainly clarified where the field needs to go.
Agreed. No shortcuts to clinical excellence, it seems.
Thanks for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.
Keep operating and keep learning.